I'm Matthew Wheeler. I'm an associate professor of medicine at Stanford University and Stanford Healthcare. I'm one of the clinicians at the Stanford Center for Inherited Cardiovascular Diseases. And today I'm going to talk about cardiomyopathy due to variants in BAG3. BAG3 is also known as the BCL2 associated athanogene number 3. But because that's a mouthful, we'll just talk about it as BAG3 cardiomyopathy for the rest of the talk. BAG3 is an interesting protein, and the variants or mutations in BAG3 have been described as causative of dilated cardiomyopathy. And about somewhere between 2 and 4% of people with a genetically positive cardiomyopathy of dilated type have variants in BAG3. We're still learning about how BAG3 causes cardiomyopathy. We're still learning about the kind of natural history of patients with BAG3 cardiomyopathy. But in general, it seems that patients who are at risk for BAG3 cardiomyopathy do have a dilated cardiomyopathy phenotype. And that means that the heart is getting larger and weaker with time without intervention. We also know that patients and families that harbor mutations in BAG3 have increased risk of both events of heart failure and arrhythmic events. Many, but not all patients with BAG3 cardiomyopathy will have progression of disease over time. In the largest natural history study of BAG3 cardiomyopathy published to date, the average age at first contact was around 40 years of age, but some patients were identified as having an abnormal heart phenotype before the age of 20, and patients beyond the age of 60 were also part of that study. So we expect that patients may present across the age span with dilated cardiomyopathy due to BAG3 variants. There's less evidence that BAG3 related cardiomyopathy affects people in infancy or very young childhood, but again, there's less data to say that with high confidence. In the largest study of clinical outcomes in patients with BAG3 mutations, it does seem that there's a worse prognosis in male versus female patients. Again, why that is not known. In patients who have a diagnosis of dilated cardiomyopathy and have BAG3 mutations, we do see evidence of events, either heart failure events or rhythm-related events, at a rate about 5% per year. Some of the unique considerations with BAG3 cardiomyopathy compared to other types of dilated cardiomyopathy are a significant rate of arrhythmias and evidence of progression even in the face of optimal medical therapy. But the overall data are relatively limited, and so we are still relying on relatively small numbers of patients to make these statements. And so I think in general, we follow a heart failure pathway with consideration of earlier surveillance and potentially treatment of arrhythmic events or phenotypes. So treatment options for BAG3 cardiomyopathy, medications will include things like beta blockers, such as Coreg or carvedilol, angiotensin receptor blockers / neprilysin inhibitors, such as sacubitril valsartan or Entresto, Jardiance or empagliflozin, dapagliflozin, medications like aldactone or spironolactone, sometimes a diuretic medication like Lasix, and there are additional medications that are emerging as typical heart failure treatments. Paired with those medications will be consideration for device therapy, such as an implantable cardiac defibrillator, a couple different types, either subcutaneous, extravascular, or intravascular. And then in a small number of people with progression of heart failure symptoms, consideration for heart transplantation. That then brings us to thinking about disease progression, both in the literature and our personal experience. There can be both gradual progression and episodic progression of disease, and that maybe those sort of episodic or sharp progression may be triggered by arrhythmia or triggered by events that lead to heart failure symptoms and need to be treated, in consultation with a cardiologist, and may require electrophysiologist or advanced heart failure specialist as well. The outlook for future therapies for BAG3 cardiomyopathy include continued advancements in the medication and device therapies that we use for dilated cardiomyopathy, regardless of genetic cause. There has been an improvement in survival and in quality of life for patients diagnosed with dilated cardiomyopathy and diagnosed with heart failure related to that dilated cardiomyopathy over the past decades. There continue to be efforts to develop new and better therapies to improve quality of life and improve quantity of life. And we do not have strong evidence to suggest that those things are not beneficial for BAG3. Another way of saying that is, to the best of our knowledge, we think that medications that help other people with dilated cardiomyopathy also help people with BAG3 related cardiomyopathy. Ongoing now, including at centers like ours, are natural history studies to better define the progress and severity of disease in patients with BAG3 cardiomyopathy. In the near future, we expect clinical trials of genetic therapies for BAG3 cardiomyopathy. This is really exciting, but also investigational. And so we do not know if in humans, genetic therapies towards BAG3 cardiomyopathy will be beneficial, will help with symptoms, will slow the progression of disease, will help prevent some of these later stage complications. But there is evidence in model systems of disease, not in humans, but in model systems of disease, that these genetic therapies may change the natural course of disease. And so we expect a lot more information about this in the next 5 to 10 years. As I said before, we have limited information about BAG3 cardiomyopathy patients. One of the ways we learn more about BAG3 cardiomyopathy patients is by learning from BAG3 cardiomyopathy patients about their disease progression, how they respond to treatment, what's happening to other family members. And it's really a partnership between clinician investigators like myself and my colleagues across the world and patients like you, and your volunteerism to help us better understand the disease and better evaluate potential treatment options. We're particularly excited that there are now multiple programs to develop BAG3 specific genetic therapies, and it's with a collaboration between investigators and clinicians like myself and people like you that we can better understand, are these therapies things that benefit patients with minimal risk? And we're hopeful that in the coming years, we'll have better information and more knowledge about how we can better treat patients with VAG3 cardiomyopathy.
This video is part of a series of educational videos developed by the Genetic Cardiomyopathy Awareness Consortium and brought to you by the DCM Foundation. Our goal is to connect you with the leading experts in the field of cardiomyopathy to further your understanding of this disease and to provide resources to help you manage your care. Thanks for watching.